Disease occurring with bronchoobstructive syndrome, bronchitis, bronchiolitis, bronchial asthma. The relevance of problem. Among respiratory disease in children, acute bronchial obstruction occurs in 30–45% of cases. Acute bronchial obstruction is a problem of children in the first year of life. It is a urgent condition requiring immediate medical attention. The complexity of differential diagnosis is one of the important problems of acute bronchial obstruction. Mechanisms of occurrence of generalized inflammation, edema of bronchial mucus, hyperextension, bronchial spasms, mucous spasms, foreign bodies, natural products of the body, saliva, gastric contents, violation of the natural purification of the respiratory tract, suppression of the cleated epithelium with impaired mucociliary clearance, cough mechanism. Mechanisms of occurrence of acute bronchial obstruction: decrease elasticity of lungs and transfusion of fluid into lumen of the respiratory tract in patients with heart failure and small cycle overload. Early expiratory closure of the respiratory tract. External factors leading to extraction: infection agents, virus, bacteria, fungi, non-infection allergens, distant smoke, tobacco smoke, aggressive gases, changes in air temperature, cold, not dry, excessive humid, neuroscientific stress. Clinical picture of exhibition: expiratory wheezing, polypnoea, wheezing during auscultation, signs and struggle, hypercapnia, changes in behavior and concessions. Acute obstructive bronchitis occurs against the background of acute renal infection and annulate wheezing exhalation, which can be hard as distance from the patient. Expiratory dyspnea occurs against a background of predisposition to allergic disease. On examination, there are chest swelling, participation in the act of respiration of the axillary muscles, retraction in the intercostal space, and there are no signs in respiratory failure. Their cough is dry, proximal prolonged, and turns into a wet on the end on the first week. In percussion, light should with a box setting, and auscultation is accompanied by dry wheezing and various side wetness. In radiological finding, you need use increased pulmonary pattern, increased transparence of lung tissue, and the absence of infiltrative and focal shows in the lungs. The algorithm of emergency care: children in 2 or 3 years immediately used oxygen therapy. In the absence of nebulizer, inhalation of the drugs through a speaker mask, used Ventolin, Ventorol, and etc. In the absence of possible treatment with nebulizer, you need used euphyllene and prednisolone. Treatment of acute bronchitis. Acute bronchitis usually does not require hospitalization. Chest range simulation, cough reflex when it decreases. Respiratory gymnastics during the covalence, prevention of dry, painful cough of the absence of wheezing in the lungs, and other signs of bronchial obstruction, mucolytic and extra agents for mucus, difficult to separate, sputum, ambraxal, bronchixin. Treatment of obstructive syndrome: 2 short-acting nebulizer, parenteral corticosteroids, and short-acting methyl oxytans. It means euphyllene. And you should use, for example, these diagnoses: acute bronchitis caused by pneumonia, acute bronchitis caused by trachomatis, acute bronchoobstructive syndromes. Acute bronchiolitis is an inflammatory disease of lower respiratory tract with a predominant lesion of small bronchial and bronchiolitis. Occurs in children under 2 years of age. In international classification of disease, you may see these codes and classification. Acute bronchiolitis caused by respiratory syncytial virus G21.5. Acute bronchiolitis caused by other specific against G21.9. Acute bronchiolitis insufficient. Etiology: respiratory syncytial viral infection is premature infants, rhinovirus, influenza A and B virus. The clinical picture: you should see severe dyspnea, perioral cyanosis, inflating with wings of the nose, unproductive cough, diffuse small moist and competing weakness in the lungs. Visually, you may see chest swelling. In percussion, a boxed sound of percussion sound. In auscultation, you should hear diffuse crepitating, swirl of bubble wheezing. Criterion: we have for prognosis severe bronchiolitis. Some of signs: it means patient's age, gestation age, general condition, respiratory rate, pulse oximetry indicate, and also X-ray information. For diagnostic, you should use now about general blood analysis. And in this case, you may see leukopenia, eosinophilia, neutropenia, lymphocytosis. And also you should know about pulse oximetry information. The following changes may occur during chest X-ray. You should use air traps. For differential diagnosis, please, you should know about obstructive bronchitis and pneumonia. Treatment: immediately use oxygen therapy and acute bronchiolitis. You should treat with hypertonic saline solution, which helps to reduce the duration of hospitalization and improve clinical parameters. Examples for diagnosis: clinical recommendation: acute bronchiolitis, respiratory failure of the 3 degree, acute bronchiolitis, respiratory failure of the 1st degree, and etc. Bronchial asthma is a heterogeneous disease characterized by chronic inflammation of the respiratory tract and its diagnosis by respiratory symptoms of wheezing, shortness of breath, chest tights of cough, variable in duration, in intensity, combined with labile area obstruction. In international clinical diagnosis and 10 rules, you may see these diagnoses: asthma with predominance of allergic component G45.0, and it means atopic asthma, and etc. Epidemiology: according in WHO, up to 250,000 people die from asthma every year. The main previous asthma regards of its severity is chronic inflammatory disease as a result of inflammatory process. 4 forms: bronchial obstruction, occur of acute bronchospasm, edema of bronchial wall, chronic obstruction by mucus and remodeling of the bronchial wall. Prolonged course of uncontrolled asthma leads to remodeling of bronchial wall and the formation of irreversible bronchial obstruction. Risk factors for asthma: can be classified with internal factors that predispose a person to develop asthma, protect against and external factors that cause onset the disease or development of asthma in people predisposed of these lead on exhibition of asthma and prolonged persistence of symptoms of disease. Factors of predisposition of asthma include genetic predisposition. The central link is an immunological predisposition, atopy. External factors contributing to the development asthma, predisposing to it: household allergens, external allergies, professional allergens, air pollution, respiratory infections, the hygienic hypothesis, parasitic infection, socioeconomic status, and fatness. Factors providing asthma exacerbation: respiratory infection, food additive medicines, excessive emotional stress, irritants such as household sprays, paint, odors. Classification of asthma severity by clinical criteria: signs before starting treatment, symptoms less than once a week, short extravagances, nocturnal symptom more than 2 times, and variability of positive severe viral. In second stage, meal-persistent asthma, you should know about symptoms more often than once a week, but less often than once a day. Exacerbation can affect physical activity and sleep. Nocturnal symptoms when in stage 3, you should know daily symptoms, exhibition of affect, physical active, nocturnal symptoms, and daily of inhaled short-acting beta-2 antagonist. In stage 4, severe persistent asthma, daily symptoms, frequent exhibition, frequent nocturnal symptoms, limitation of physical activity. The severity of asthma is defined by taking into account anamnestic date, introduction of clinical and functional examination before the start or against the background of basic therapy. Diagnosis of asthma in children. The diagnosis of asthma in children is clinical and is established on basis of complaints and anamnestic date of patient. An assessment of lung function, forced vital lung capacity, peak expiratory velocity. The main direction in the treatment of asthma: elimination of effects of causal factors, prevention therapy, pharmacotherapy, allergovaccination, rehabilitation, addition of patient and their patient. Pharmacotherapy: control drugs, anti-inflammatory drugs, inhaled corticosteroids, long-acting bronchodilators, salmeterol, formoterol, and etc. Medication that relieve the condition: fast-acting beta-2 agonist. It means salbutamol, phenaterol, terabutolin. Recommended medication depending on the severity of disease in children under 5 years of age for all levels. In addition to taking daily medication to control the disease, a rapid-acting inhaled beta-2 again should be used as needed, but more than 3 or 4 times a day. And in these in the slides, you see degree of severity, step by step. In stage 1, intermediate, there are daily intake of medical medication to control the disease are not needed. In stage 2, mild persistent asthma, you should use medicine in low doses. And step 3, persistent asthma, moderate severity, you should average dose all these medication. And in step 4, severe persistent asthma, high doses all medication, fixed combination, and slow release theophylline systemic glucocorticosteroids. Currently, treatment in bronchial asthma recommended to begin at the early stage of treatment the disease, continue for a long time. Starting doses should be high enough, and the achieved result can be maintained with a low dose medicine. Also, it's very important in this case that diet therapy. Prevention of asthma. In modern clinical allergology, the first step of the allergic match is a genetic predisposition to atopy. The second step is the development of food sensibilization and the formation of allergic skin lesions of the child. The next steps of the allergic match are the expansion of the spectrum of cyspillation to household epidermal and pollen allergens, and the formation of allergic disease of the respiratory tract. In this regard, there are 3 levels of prevention work: primary, secondary, and tertiary prevention of bronchial asthma.